Hello everyone, welcome back. Today I'll be covering Osteosarcoma, a part 1 video. This includes introduction, epidemiology, etiology, genetic aberrations in primary osteosarcoma, types of osteosarcoma, history and physical examination. Now let's get started. As an introduction, osteosarcoma, also known as osteogenic sarcoma, it is a primary malignant bone tumor affecting mostly children and adolescents. This by Wang et al. 2020. It is characterized by the production of an osteomatrix or immature bone by the malignant cells. It has been reported that the 5-year survival of patients with osteosarcoma has increased from less than 20% in the 1970s to 60 to 70% currently due to the advancement of surgical resection with adequate margins and neoadjuvant therapy. Based on Miwa et al. 2019. Osteosarcoma patients are prone to relapse, and pulmonary metastasis is the most common site. However, around 15 to 20% of patients with osteosarcoma are expected to have clinically detectable metastasis at the time of initial presentation. By Isakoff et al. 2015, with the most metastasis occurring in the lungs. The overall 10-year survival of patients with metastatic osteosarcoma are less than 20%. Study by Kansara et al. 2000. Osteosarcoma and Ewing sarcoma are the two malignant bone cancer that affects the children and adolescents, and they represent about 56% and 34% bone cancer, respectively. Epidemiology. Osteosarcoma can occur in primary, that means no underlying bone pathology, and secondary forms, underlying pathology which has undergone malignant degeneration or conversion. Osteosarcoma has bimodal age distribution. The initial peak is in the 10 to 14 years of age group, corresponding to the pubertal age group. The next peak in adults more than 65 years old, likely to present as a result from malignant degeneration of Paget's disease, sites of bone infarction, etc., etc. Etiology. Osteosarcoma is highly heterogeneous in its manifestation, which permits division into several subtypes according to the degree of differentiation, location within the bone, and histological variation. Several genetic aberrations in cases of primary osteosarcoma. Number 1. Hereditary Retinoblastoma, an autosomal dominant condition caused by germline mutations in RB1 gene, caused by bilateral retinoblastoma. Noted at the age of 1 year old, retinoblastoma characterized and it presents an absence of the red reflex in the eye. This disorder has high risk of osteosarcoma later in life. Number 2, Li-Fraumeni syndrome, an autosomal dominant disorder due to the mutation in the p53 tumor suppressor gene. Number 3, Rothmund-Thomson syndrome, an autosomal recessive syndrome due to a mutation in the RECQL4 gene. Number 4, Bloom syndrome, an autosomal recessive disorder caused by mutation in the BLM gene. Number 5, Werner syndrome, an autosomal recessive disorder, also known as adult progeria, is due to faulty WRN gene. The types of osteosarcoma. Osteosarcoma is grossly divided into various subtypes based on its location within the bone, then further subdivided by grade. Again, the WHO histologic classification of bone tumors divides osteosarcoma into central, intramedullary, and surface tumors with a number of subtypes under each group. For number 1, central or intramedullary, a high-grade central is conventional osteosarcoma. Conventional osteosarcoma is the most common type of osteosarcoma and represents 80% of all osteosarcoma cases, primarily affecting individuals in the first and second decades of life. It can be subdivided into osteoblastic, chondroblastic, and fibroblastic groups depending on the predominant features of the cells. There are no significant differences in clinical outcomes among the categories. Osteosarcoma is high-grade and originates in the intramedullary cavity. On radiograph, osteosarcoma can be osteolithic or osteoblastic or both. 80% are located in the metaphysis of long bone, but osteosarcoma can also arise in the diaphysis of long bones as well as the axial skeleton. This X-ray shows an osteolithic lesion with cortical thinning. You can see a sunburst appearance, shows high-grade tumor, and an osteoblastic lesion at the distal femur. Number 2, Telangiectatic osteosarcoma, TOS, accounts for 4% of osteosarcoma. Histologically, dilated blood-filled cavities and high-grade sarcomatous cells on the septae and peripheral rim characterize TOS. Radiographically, TOS is metaphyseal with geographic patterns of bone destruction and a wide zone of transition. Moth-eaten or permeative destruction can be seen. It is important to differentiate TOS from aneurysmal bone cyst ABC on imaging. ABC is described as an eccentric lithic lesion with a blown-out space in the bone. This figure shows the histologic features of telangiectatic osteosarcoma that mimic aneurysmal bone cyst. You can see a blood-filled cystic space separated by delicate septa. There's also cell lining of the septa that are cytology malignant. Number 3, small cell osteosarcoma, SOS. SOS constitute 1 to 2% of all osteosarcoma. The histological features of SOS shows cells that are small and have round hypochromatic nuclei with little nuclear polymorphism similar to Ewing sarcoma. However, while the production of osteoid by tumor cells confirms the diagnosis of osteosarcoma, it is not a characteristic feature of Ewing sarcoma. A destructive process with lytic areas and sclerosis is found on radiograph. This X-ray shows a mixture of osteolytic and osteosclerotic lesions in the metaphyseal region of the left proximal tibia. Number 4, a low-grade osteosarcoma, LOS. It accounts for 1 to 2% of all osteosarcoma. However, LOS generally affects persons in the 3rd or 4th decade of life. LOS can be difficult to recognize as it is low-grade and may resemble parosteal osteosarcoma, fibrous dysplasia, or desmoplastic fibroma. While there is a risk of transformation to conventional osteosarcoma if treated with curettage alone, the prognosis is significantly better in LOS. This X-ray of distal femur shows a solitary bone lesion that may mimic fibrous dysplasia or desmoplastic fibroma. Number 2, surface or periosteal or cortical. A for low-grade surface is parosteal osteosarcoma, PAOS. It is found on the outer periosteal surface of the bone. That means originates from the periosteum. PAOS represents 4 to 6% of osteosarcoma and commonly affects the posterior aspect of the distal femur. It may occur in other sites including the proximal humerus and proximal tibia. Radiograph demonstrate a densely ossified and lobulated mass, while the medullary cavities are spared. Histologically, features ribbons of osseous trabeculae orientated in parallel, primarily composed of a chondroid matrix with only a minuscule amount of osteoid matrix. This X-ray shows a lobulated juxtacortical mass with dense calcification and smooth borders arising from the lateral cortex of the right femoral metaphysis. There is no aggressive periosteal reaction. Superiorly, a thin radiolucent line separates the tumor from the cortex. B. Intermediate grade surface. Periosteal. Found between the cortex and the inner periosteal surface of the bone. Periosteal osteosarcoma, PIOS, has a matrix component that is mainly cartilaginous and less common than parosteal. PIOS tends to arise between the cortex and the cambium layer of the periosteum, and therefore a periosteal reaction is usually visible on the radiograph. On histopathologic examination, an intermediate grade tumor is seen, containing a cartilaginous matrix with areas of calcification. This X-ray shows a sunburst or hair on an periosteal reaction. It arises between the cortex and the cambium layer of the periosteum. C for high-grade surface, HGSOS. It constitutes less than 1% of all osteosarcoma. That means it's rare. Radiographically, HGSOS demonstrates a surface lesion with partial mineralization, and the tumor may extend to surrounding soft tissues. Histological identical to high-grade or conventional or central variant, it varies only in location. That means being confined to the surface of the bone, which is thought to represent the differential parosteal osteosarcoma. Again, this X-ray of distal femur shows a high-grade osteosarcoma that develops on the surface of the bone from the outer cortex. Appearance similar to periosteal osteosarcoma, but usually with more ossification. Codman's triangle or malignant periosteal reaction may be present. What are the sites of osteosarcoma? The most common sites for osteosarcoma are the femur, 42%, whereby 70% of them are in distal femur. The tibia constitute 90%, whereby 80% of them are in the proximal tibia, and the humerus, 10%, whereby 90% of which are in the proximal humerus. Other potential sites include the skull or jaw, 8%, and the pelvis, 8%. Osteosarcoma can be subdivided into primary and secondary form. A. Primary tumor usually occur in the metaphysis of long bone, common in the knee. B. Secondary tumor has wider distribution, reflecting the varied nature of their underlying predisposing condition. Higher incidence in the flat bones, the pelvis in particular, whereby it's a common location of Paget's disease. History-wise, patient present with history of bone pain, particularly with activity. Pathologic fracture is not common except for the telangiectatic type of osteosarcoma. The resulting pain may manifest as a limp. A swelling or lump may or may not be reported depending on tumor size and location. Systemic symptoms, fever, night sweats, are rare. Respiratory symptoms are also rare and when present indicate extensive lung involvement. For physical examination, focus around the location of the primary tumor, and this may include palpable mass, may be tender and warm with or without overlying pulsation or bruit, though these signs are non-specific. Joint involvement with decreased range of movement. Local or regional lymphadenopathy but is rare. Respiratory findings with metastatic forms. Yay, we have reached to the end of this video. See you in the part 2 video. Take care and bye.